So the first class of agents that we're going to talk about is the folic acid agents, or the folic acid antagonists. And the idea of folic acid antagonists is you're trying to make, the end goal of this whole process is you're trying to make some purines to make DNA. And how it starts is you have para-amino benzoic acid, PABA, and it comes with this molecule pyridine, and it makes this molecule dihydrotoroic acid using this enzyme dihydrotoroate synthase. And this enzyme is inhibited by the sulfonamides or dapsone. And then there is a second step using dihydrofolate reductase to make tetrahydrofolate or tetrahydrofolic acid. And this enzyme is inhibited by trimethoprim and pyrimethamine. So if you think about it, if you use these compounds, you're going to stop making folate. Actually, also, if you use it in combination, quote-unquote synergy, you'll have a greater effect. And that's the whole idea of combining. You can combine sulfonamide and trimethoprim. So let's talk about it in detail. So sulfamethoxazole is our first example. So it inhibits folate synthesis via blocking dihydrotoroate synthase. So it's very important to know that sulfa inhibits the synthase. Sulfa inhibits the synthase. The uses, I don't want you to get caught up for the uses because that's something that we'll talk about later in the year. And you'll talk about it in micro 2, but it's used for gram-positive and gram-negative organisms. It's broad spectrum. It's used for nocardia, simple UTI like E. coli, and then PCP treatment, or as they call it now, PJP, treatment and prophylaxis. Side effects for sulfa can cause some hypersensitivity reactions. It can also cause some hemolysis. So in patients that have G6PD deficiency, so this is the enzyme that makes glutathione and protects against the reactive stress of the red blood cell, sulfamethoxazole actually causes an oxidative stress on the red blood cell. So if you have a patient that has G6PD deficiency, you'll get hemolysis. Causes also some photosensitivity. And the most worrisome, actually this is probably the highest yield side effect point of sulfonamide, is it can cause Stevens-Johnson syndrome. And Stevens-Johnson syndrome is this slouching of the skin layers, and it mimics burn, and it can actually be life-endangering situation. So Stevens-Johnson syndrome can be caused by sulfonamides. And last thing is that sulfonamides can cause kernicterus. And kernicterus is pretty much a jaundiced baby that has a lot of bilirubin that's not displaced. And the whole idea is that sulfonamides displace the bilirubin that's bound to albumin and makes the free bilirubin, and it causes the baby to be jaundiced. So biggest high yield for sulfonamides inhibits synthase, and then G6PD, Stevens-Johnson, and kernicterus. Now with its cousin, trimethoprim. And trimethoprim is, actually I would say its younger sibling. It inhibits bacterial dihydrofolate reductase. So sulfamethoxazole inhibits synthase, and trimethoprim inhibits reductase. And the reason why I stress this is because you can see it in some of the questions of what is it specifically that these medications inhibit. It's combined with sulfonamides, and the medication is called Bertram. And when you go on clinical rotations, you'll hear Bertram a lot. It's used in synergy, so this combination is called synergistic because one effect of medication is sort of multiplied when you add another medication to it, and it's pretty much used in the same things that sulfamethoxazole uses to treat. So this is the first class of medications, the anti-folates. The second class of medications is the DNA inhibitors. So now you're trying to inhibit DNA from being made. So the classic agents for DNA inhibitors is the fluoroquinolones. And examples of the fluoroquinolones is ciprofloxacin, and levofloxacin. There is a whole bunch of other ones that are on your list, but I chose just these two because these are probably the most important. And you can get that a medication is a fluoroquinolone from the suffix. It's floxacin. Floxacin. And how the fluoroquinolones work is that they inhibit the prokaryotic topoisomerase 2 and topoisomerase 4. So as you remember, these are the medications that help unwind the DNA, that cause a little bit of nicks in the DNA so that it doesn't break. So if you inhibit these enzymes, the DNA is going to break and you're not going to be able to replicate it. The fluoroquinolones are mainly gram negatives, but they have some gram-positive coverage. The biggest thing that fluoroquinolones do is that they cover Pseudomonas. They have a great Pseudomonas coverage, and they have other gram-negative rod coverage. So they're used for urinary and GI infections. Side effects is a pretty important high yield for fluoroquinolones is that they can cause Achilles tendonitis. So think of the fluoroquinolones as sort of like attacking your tendons, and it causes tendon ruptures. And it's actually contraindicated in elderly and children because these populations, the elderly and the children, are at increased risk for tendon rupture. The other side effects for the fluoroquinolones, and unfortunately this one you'll have to memorize, is that it can prolong the QT interval. And if you have a patient that has an already prolonged QT, you don't want to use fluoroquinolones in it. And just a small clinical pearl is that the fluoroquinolones, when you give it, you have to give it on an empty stomach with no antacids because they go in and they bind the antacids and they're not going to be absorbed. So that's a little bit of a clinical pearl with the fluoroquinolones. So summary for the fluoroquinolones: topo 2 and 4 inhibitors, Pseudomonas, Achilles tendonitis, prolonged QT, no antacids is not a very high yield point. And that concludes our first discussion with the antibiotics. Okay guys, welcome back, and we're finishing our discussion of the antibiotics, and this is just a couple miscellaneous antibiotics that we're going to talk about, and um, antibiotic spectrum of activity and some mechanisms of resistance. So with the last couple antibiotics that we're going to talk about, the first one is called metronidazole. And metronidazole is sort of a weird antibiotic. It actually forms toxic free radicals, and these free radicals go after the DNA and it damages the DNA, so the DNA can't replicate. It's used for protozoa and anaerobes, so protozoa Giardia, Entamoeba, Trichomonas, Gardnerella, and anaerobes, so Bacteroides, C. difficile. Side effects for metronidazole is two biggest ones. The first one is disulfiram-like reaction. So do you guys remember where we talked about disulfiram-like reaction? Yes, procarbazine in the cancer section. So metronidazole has the same side effect. It inhibits aldehyde dehydrogenase, so you end up having a lot of aldehyde hanging around in the system, and that causes severe flushing with alcohol. The second side effect actually gives a pretty bad metallic taste in the mouth, so patients don't end up liking metronidazole, but it's a commonly used medication. The second miscellaneous medication that we're going to talk about is nitrofurantoin. We actually don't really know how it works, so you're not expected to know anything about its mechanism. What you are expected to know is its uses. So it's used for E. coli and uncomplicated UTI because it actually concentrates in the urine, so it's pretty good for E. coli coverage. Side effects for nitrofurantoin is high yield as well. It turns the urine brown color, and the reason for that is the medication itself is brown, and it's something that's harmless. But the more harmful side effect is pulmonary fibrosis. So nitrofurantoin causes pulmonary fibrosis, and that's something that that you are expected to know as well, and it's a high yield point that examiners like to go after. Actually, on my step 1 exam, I had a question that was it went like this. It was saying 23-year-old female with history of recurrent cystitis that was coming in with shortness of breath, and she ends up having restrictive lung disease. What is the cause of her restrictive lung disease? And the cause was that she was put on this medication nitrofurantoin for prophylaxis of cystitis or UTI. So pretty important high point to keep note of. Rifampin is the third miscellaneous drug that we're going to talk about, and rifampin it inhibits the bacterial DNA-dependent RNA polymerase. So what does the DNA-dependent RNA polymerase do? Yes, transcription. So it makes mRNA in order for the mRNA to go out and eventually make proteins. So in a big picture type of question, rifampin inhibits transcription. It's used for mycobacteria, which is tuberculosis or leprosy. It's also used for Haemophilus prophylaxis and Neisseria meningitidis prophylaxis as well. Side effects are kind of important. It causes hematologic side effects, so thrombocytopenia, leukopenia, and anemia. And if I want to lump all of these in one word, what would it be? Yes, pancytopenia. Also, it causes renal side effects, so nephritis and proteinuria. But also, an important side effect is that it turns the bodily fluid, it turns them an orange color. So urine, sweat, and tears. And patients actually who take this will come freaking out, saying that they have red or orange tears, and they kind of feel like zombies. And you do not need to worry, and you tell the patients not to worry because they are taking rifampin, and that's just a side effect. And it's also harmless, same as nitrofurantoin. And the last side effect that I would like you to be aware of, and it's actually highly tested, is that rifampin has a lot of drug interactions. And the reason for that is that it induces the CYP450 enzymes. So it makes these enzymes hyperactive. And one famous side effect is it decreases the effectiveness of oral contraceptives. So you'll have a patient, or the question will go like this: patient taking rifampin, let's say for Neisseria meningitidis prophylaxis, and she ends up getting pregnant. Why did she get pregnant? And it's the reason because the CYP enzymes were induced. So that's kind of the question that you'll get on rifampin. So that really concludes the specific antibiotics section. I wanted to take a few minutes to talk about antibiotic spectrum. So the word spectrum really means what does the antibiotic cover, which bacteria it covers. So some antibiotics are narrow spectrum, which means they cover one or two bacteria, or or three, and some antibiotics are broad spectrum, which means they cover a lot of number of bacteria. And I put these slides for you. Really, when we put these slides, me and Mike, it was intended for end of the year antibiotic review for last year. But I also wanted to put it here in case you want to refer back to it as you're studying for micro. This is not. You are not expected to know all of these for your pharm test, but it's pretty helpful for micro as you're going through your micro studying, and eventually for step one you'll be expected to know them. I will not go through all of these, but they're here for your information. What I will go through and what I want you guys to focus on is what drugs cover MRSA, which is methicillin-resistant Staph aureus, and what drugs cover Pseudomonas. So these you will be tested on, again, not for this exam specifically, but more for step one. And I want you to have sort of like a background on what covers MRSA and what covers Pseudomonas. So MRSA, it can be classified into either community acquired or healthcare associated. Most likely you will be tested on the healthcare associated MRSA, but it's also good to know the community acquired MRSA. So the drugs that cover the community acquired MRSA is Bactrim, which is trimethoprim and sulfamethoxazole, doxycycline, and clindamycin. So these are the three biggest drugs that cover community acquired MRSA. The healthcare associated MRSA, vancomycin covers it, which is our first line for MRSA, daptomycin, linezolid, tigecycline, and ceftaroline. And do you remember what ceftaroline is? Yes, it's one of the 5th-generation cephalosporin, and it's the only one with it's the only cephalosporin with MRSA coverage. So that's as far as MRSA infections. For Pseudomonas infections, which is gram-negative, it's a pretty nasty bug, and you need a heavy-duty antibiotic to cover it. So first line for Pseudomonas is Zosyn, so piperacillin and tazobactam. Aminoglycosides are pretty good at Pseudomonas coverage. Aztreonam as well. And do you remember what aztreonam is? Yes, it's one of these one-ringed penicillin that doesn't cross-react with penicillins, and you can give it to patient with penicillin allergies. Good job. Um, Ceftazidime, which is a 3rd-generation cephalosporin, covers Pseudomonas. Cefepime covers Pseudomonas, and then the carbapenems, meropenem, imipenem, and also fluoroquinolones, Cipro, and Levo. So I think it's good to have a mental picture of which drugs cover Pseudomonas and which drugs cover MRSA. It's really good to keep those in mind. Lastly, what I wanted to touch about is antibiotic resistant, and I wanted to put this at the end is because you might get 1 or 2 questions on it on the pharm exam, but definitely a lot of question on step one exam, and when you're doing UWorld, you'll see a lot of questions on antibiotic resistance, and it can be a little bit challenging studying about antibiotic resistance, but I think I wanted to give it to you in 1 sentence. If you understand the concept of antibiotic resistance, you'll pretty much get 90% of the questions correct. And the whole concept is that think about how the drug works. If you think about how the drug works, the bacteria have pretty much developed a resistant mechanism to how it works. So let's take an example. So for example, penicillin. So how do the penicillins work? First, they alter. First, they bind peptidase, which is the penicillin binding protein. And you remember what that does? Yes, that cross-links the peptidoglycans. So bacteria is kind of smart. They alter this peptidase enzyme. So that's the mechanism for penicillins and cephalosporins. Do you guys also remember the enzyme penicillinase, which is beta-lactamase? Yes, that's the enzyme that cleaves the beta-lactam ring, and that's the mechanism of resistance for penicillin and amoxicillin. And lastly, bacteria can kind of make these. So you have small pores that allow the antibiotics to get into the cell. Bacteria can mutate these pores, and the drugs cannot diffuse into the cell. So that's also one of the resistant mechanism. But by far, the first 2 are the more important. For vancomycin, do you guys remember how does vancomycin work? Yes, it binds D-ALA, and it prevents the peptidoglycans from binding together. So for the mechanism of resistance for vancomycin, it uses D-ALA D-lactate. So the bacteria use this cross-link instead of the D-ALA D-ALA, and you get a mutated peptidoglycan cell wall. Also, you have some impaired influx, so the antibiotic can't get into the cell, and increased efflux, so the bacteria kick out vancomycin outside of cell. The third antibiotic is quinolones. Do you guys remember how quinolones work? Yes, they work by inhibiting DNA gyrase or topoisomerase. So quinolones, bacteria have developed a resistance to it by mutating the DNA gyrase, and that's a chromosome gene. You also have some efflux pumps, and that's a plasmid gene. So a lot of these also have like these efflux pump that kind of kick out the antibiotic from outside of the cell. Fourth is aminoglycosides. So we know that aminoglycosides work by inhibiting the ribosome. So the mechanism of resistance is that you can mutate the ribosome. Also, the bacteria sort of creates these modifying enzymes by acetylation, phosphorylation, or adenylation, and they inactivate the aminoglycosides. Chloramphenicol, it inhibits the 50S ribosome, but this one is sort of non-specific, so unfortunately you have to memorize it. It's inactivated by a plasmid-coated acetyltransferase. Linezolid inhibits the 50S ribosome, and its resistance is a point mutation of the ribosomal RNA. Macrolides inhibits the 30S. sorry, I apologize, the 50S. And they the mechanism of resistance is decreased binding to the 23S rRNA, and that's via methylation. Tetracycline's mechanism of resistance is decreased uptake or increased influx. And rifamycin, which is pretty much rifampin, you get a mutated RNA polymerase. And lastly, the antifolates, which is the sulfamethoxazole uh, and trimethoprim, you have a mutated or increased folate synthesis enzymes. So really, if you think about how the drug works, with few exceptions, you'll be able to get the question correctly. So that concludes our whole presentation and the antibiotic presentation. I know that was a lot to cover, but please go through it one by one. If you master the antibiotics, I think it'll make your life much, much easier in micro and of course in farm. Best wishes for you guys. I hope this exam goes well for you. If you have any questions, please reach out to myself or Mike. We'll be more than happy to answer your questions.